Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Health Insight, and I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They're brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. So without further ado, we're very excited about today's presenter on MDS coding for the pain quality measure. We have Jessica Mirabal from Genesis. She's an RN and a clinical reimbursement manager with Genesis Healthcare. She has 8 years experience in SNF long-term care settings. She spent 2 years as a clinical reimbursement manager, 4 years as a director of nursing, and 1 year as an assistant director of nursing. And we're delighted to have her for a second time present to our group. So I will turn things over to Jessica Mirabal. Jessica, you may get started.
Thank you, Shannon. So in today's presentation, I want to go over MDS coding for the pain quality measure. And upon completion of this training, you will know the requirements per the RA manual of coding the pain interview in Section J, how the coding of the pain interview on the MDS affects the quality measure rating, and then helpful tips on reducing and evaluating pain in your facility related to the quality measure reporting. So remember, when it comes to pain is subjective. It is a reason to seek medical attention, and it can compromise care. Any type of physical pain or discomfort in any part of the body may be localized to one area or may be more generalized. It can also be acute or chronic, continuous or intermittent, or occur at rest or with movement. Pain is, again, like I said, very subjective. It's whatever the experiencing person says it is and exists whenever he or she says it does. Pain is one of the most common reasons people seek medical attention, and it's often regarded as the fifth vital sign. Pain is also frequently perceived to be underassessed and undermanaged. Uncontrolled pain not only results in unnecessary suffering, but compromises the care of underlying diseases and can lead to decrease in ADL function, increase in skin impairments, and an increase in fall risk, to name a few. In relation to the quality measure, pain will impact a myriad of measures. By addressing the causative factors of pain, can quality of care be improved, which in turn will increase the quality measure rating? And that's something that we're going to explore today. So Section J is the part of the MDS that is utilized to code the pain interview. And the MDS is utilized when calculating the quality measure. And the MDS utilizes data from center assessments, which are routinely collected and submitted to CMS. Again, MDSs are required for every resident in a Medicare or Medicaid certified facility. MDSs are completed at regular intervals as defined by the RAI manual. And the MDS information includes resident health, physical function, mental status, general well-being, and certain demographic information. Much of this information changes as residents are admitted, discharged, and their conditions change. So let's look at one of the first questions in Section J of the MDS, and that's J0100, pain management. It is a 5-day look back, and what it does is it determines, does the resident have a scheduled pain medication regimen? Did they receive any PRN as needed pain medication? And did they receive any non-medication interventions for their pain? A scheduled pain medication regimen is defined as pain medication order that defines dose and specific time intervals for pain medication administration. So, once a day, every 12 hours, something like that. PRN pain medication order that specifies dose and indicates that pain medication may only be given on or as needed basis. And so that includes time intervals such as every 4 hours as needed, every 6 hours as needed. And then non-medication pain interventions are defined as scheduled or implemented non-pharmacological interventions. They include, but are not limited to, biofeedback, application of heat and cold, massage, physical therapy, stretching, exercise, herbal or alternative medicine products are not included in this category. So that's one thing to keep in mind. And this is one of the first areas that I'd like to look at when we're addressing a resident's pain. I think it's an area that will start the deep dive into why a resident is experiencing pain. If a resident is having a lot of pain and they only have a PRN pain medication, then maybe we need to look at that scheduled regimen. Or maybe we have scheduled in PRN and we're not necessarily addressing the non-pharmacological interventions. So this one question of the MDS can help us dive into how we are managing a resident's pain. The next question in section J that we'll go into is J0200. And this is, should a pain assessment interview be conducted? And remember that most residents who are capable of communicating can answer questions about how they feel. Obtaining information about pain directly from the resident, sometimes called hearing the resident's voice, is more reliable and accurate than observation alone for identifying pain. If a resident cannot communicate, such as verbal, gestures, or written, then a staff observation for pain behavior should be used. Remember, we should attempt to complete the interview if the resident is at least sometimes understood or an interpreter is present or not required. So based off of our answer in J0200, that will then lead us into J0300 to J0600, which is that pain assessment interview. And your pain quality measure derives specifically from these questions, J0300 through J0600. Remember that assessment of pain provides insight into the need to adjust the timing of pain interventions to better cover sleep or preferred activities. Pain assessment prompts discussion about factors that aggravate and alleviate pain. Similar pain stimuli can have varying impacts on different individuals. Constant use of a standardized pain intensity scale improves the validity and reliability of pain assessments. And using the same scale in different settings may improve continuity of care. Pain intensity scales allow providers to evaluate whether pain is responding to pain medications and or non-pharmacological interventions. Remember that in J0300, this is a 5-day look back. And what you want to do is you want to ask the resident, have you had pain or hurting at any time in the last 5 days? And rates of self-reported pain are higher than observed rates. Although some observers have expressed concern that residents may not complain or may deny pain, the regular and objective use of self-reported pain scales enhances residents' willingness to report. And I think this is one of the most important questions we can really ask our residents when we're working with them is, have you had any pain? And one of the misconceptions related to quality measures is related to this question. That people think that if we ask them these questions, they're gonna rate their pain a little higher, and I don't believe that's necessarily true. So this is a yes or no question. You would code yes if they had pain in the last 5 days, and you would code no if they haven't. There are some codes that you can use if the resident is unable to answer. Then you would jump into J0400, which is pain frequency. Again, this is a 5-day look back. It's the pain interview is a little bit different look back than other areas of the MDS. And so what you want to ask is how much of the time have you experienced pain or hurting in the last 5 days? Staff may present response options on a written sheet or cue card. And I think this is one of the best suggestions out there is, you know, ask them verbally, but also show them in writing, because maybe they didn't catch everything that you said when you were asking the resident. And so if they're able to read, they can actually comprehend the question that you are asking them. If the resident provides a related response but does not use the provided response scale, help clarify the best response by echoing or repeating the resident's own comments and providing related response options. This interview approach frequently helps the resident clarify which response option he or she prefers. If the resident, despite clarifying the statement and repeating response options, continues to have difficulty, select between two of the provided responses, then select the more frequent of the two. And so the way that you would code this is almost constant, frequent, occasional, rare, or unable to answer. And where your quality measure is going to trigger is almost constant or frequent. If your resident is saying that they're experiencing pain at these intervals, then you're definitely going to trigger your quality measure. The next question is J0500, which is pain effect on function. Again, it's a 5-day look back, and you're going to ask the resident 2 questions. And again, with any interview on the MDS, you have to ask them the way the question is worded, the way it's written. So over the past 5 days, has pain made it hard for you to sleep at night? And over the past 5 days, have you limited your day-to-day activities because of pain? If the resident response does not lead to a clear yes or no answer, repeat the resident's response and then try to narrow the focus of the response. For example, the resident responds to the question, has pain made it hard for you to sleep at night? By saying, I always have trouble sleeping. Then the assessor might reply, you always have trouble sleeping. Is it your pain that makes it harder for you to sleep? Which will then guide them into basically a yes or no answer, which will then reflect in this portion of the MDS. Again, like I mentioned, it's a yes or no question, and then you are able to code if the resident is unable to answer. J0600 is that pain intensity. And again, it's a 5-day look back, and you either want to use the numeric rating scale, and just as the name implies, it's a 0 to 10 scale, or you may want to use the verbal descriptor scale. And so the verbal descriptor scale it goes mild, moderate, severe, very severe, horrible. And so the thing to keep in mind when it comes to J0600 is if a resident rates their pain 5 or above, they're going to trigger on your quality measures. And if they use the verbal descriptor scale, then they're looking at moderate to severe or very severe, horrible. If they rate it anywhere in that group, your quality measure is going to trigger. So you want to, read that question and item choices slowly. While reading, you may show the resident response options. So have that numeric rating scale or verbal descriptor scale printed out on a piece of paper. I recommend an 8x10 because generally the information that's going to be on there is going to be at a font size that most residents are able to read. Again, use that large clear print. For the numeric rating scale, you would want to ask them, please rate your worst pain over the last 5 days, with 0 being no pain and 10 being the worst pain you can imagine. That way they can kind of have an idea of how the scale is set up. You want to use the same scale every single time you're conducting this interview. So if you do the interview and you start out with the numeric pain scale, you want to stay with that numeric pain scale while that resident is in your facility. You don't want to go numeric then verbal, or however the variations can occur. You want to stick to that same scale all the time. So now that you know how to code Section J and kind of how it has an effect on your quality measures, let's actually jump into the quality measure rating system. And so in December of 2008, the 5-star quality rating system was added to Nursing Home Compare for all nursing homes participating in Medicare or Medicaid. The goal is to provide residents, families, and consumers a way to compare nursing homes more easily and to help identify areas about which they may want to ask questions. The 5-star rating system features an overall rating of 1 to 5 stars based on facility performance for 3 types of measures, each with its own 5-star rating. So they look at health inspections, staffing, and then quality measures. The quality measure aspect is based on performance in 16 of the 24 quality measures that are posted on Nursing Home Compare. And these are based on information derived from the MDS 3.0. They also have claims-based measures which utilize hospital and ED claims. There are 9 long-stay measures and 7 short-stay measures that are utilized for the calculation. The long-stay measures are as follows. So ability to move independently has worsened. Residents who need for help with activities of daily living has increased. High-risk pressure ulcers. Residents who have or had a catheter inserted and left in their bladder. Residents who are physically restrained. Urinary tract infections. Residents who self-report moderate to severe pain, experiencing 1 or more falls with major injury, and residents who receive antipsychotic medications. For your short stay measures, you're looking at physical function improves from admission to discharge, residents with pressure ulcers that are new or worsened, residents who self-report moderate to severe pain, and those who newly receive an antipsychotic. The claims-based measures are residents who are re-hospitalized after a nursing home admission, short-stay residents who have an outpatient ED visit, and percentage of short-stay residents who were successfully discharged to the community. So now let's dive into the actual quality measure, which is percentage of residents who self-report moderate to severe pain. So the first one we're going to look at is the short-stay measure. So what is a short-stay? It's defined as a resident whose latest episode is less than or equal to 100 days in cumulative days in the facility, or CDIF. This measure captures the percentage of short-stay residents with at least 1 episode of moderate to severe pain or horrible excruciating pain of any frequency in the last 5 days. Short-stay residents, so again, anyone who's been in your facility 100 days or less, with a selected target assessment where the target assessment meets either or both of the following 2 conditions. So condition 1 is resident reports daily pain with at least 1 episode of moderate to severe pain. Both of the following conditions must be met, so almost constant or frequent pain and at least 1 episode of moderate to severe pain. Condition 2 is residents reports very severe horrible pain of any frequency. So to break this down, if, as I mentioned before, if they rate their pain, say 5 to a 9, and they rate their pain almost constant or frequent, they're going to trigger. Or if they rate their pain at a 10 or severe horrible, then it doesn't matter at any frequency, they're going to trigger your quality measure. So there are exclusions to this quality measure, and basically it's if the information is not there, it's dashed. So if we dash any part of the pain interview, they will not be included in that quality measure reporting. This is a cut table, and as you can see, the top portion, which will give you 100 points towards your quality measures, 7%, they give you that threshold with your short stay residents. And you want to make sure that, you're looking at this. I like these cut tables because then when I'm looking at my percentages on my CASPER reports, it's kind of giving me an idea of how much progress we've made, but also where we're at in our point systems. I may be getting 60 points right now, and my current percentage is at 13.3. I know if I could maybe reduce one more resident with address that resident's pain, that I may get another 20 points and bump into that 80 point group. And again, just looking at those numbers, seeing the progress you've made with the residents that you've addressed. The long stay measure is pretty much the same. And so this is one of the few measures that are both in the long and short term that have very similar requirements. And so the only difference is a long stay measure is defined as an episode greater than 101 days. So 100 or less is a short stay, 101 or greater is a long stay measure. Again, it's very similar in how it's captured. It's that severe, almost constant, or occasional or almost constant, and moderate to severe pain. Or I'm sorry, almost constant or frequent pain and moderate to severe in nature. And then, as always, severe or horrible is always going to trigger regardless of how often it's occurred. The exclusions are kind of similar. Again, it goes back to if that information is not complete, which is indicated by a dash on the MDS, or if the numeric pain intensity item indicates no pain. This cut table is a little bit different. It, as you can see, it goes down to, what is that, 2%? So it's not as forgiving as that short stay measure. So you do want to, look at where you are on your ratings and see what you need to do to get to, ideally 0%. You would hope that there are no residents in your facility experiencing pain. In reality, we know that that's not possible, but you want to get as close to 0% of your residents as possible, so that, one, you have a healthy population that's not experiencing pain and doesn't have that negative outcomes related to the pain that they're experiencing. So my hope is that those of you that are on this presentation have access to the CASPER reporting system. The reports that are generated are very helpful in evaluating your quality measures. I would recommend that you pull these reports at least monthly, and I recommend pulling the MDS 3.0 QM package report. This will include facility characteristics, your facility level quality measure report, as well as your resident level quality measure report. The timeframes, one thing that I recommend is I would evaluate quality measures month over month. And if you're doing a month over month and then as a quarter, you're addressing them practically in real time. And so it doesn't become burdensome towards the end of the month or the end of the quarter, and you're not trying to address numerous quality measures. If you're doing it month over month and then for that entire quarter at the end, then it's a little bit more manageable. So as an example, in February, you would just pull, say, January's. In March, you'd pull January and February. In April, which is the start of a new quarter, you're pulling the entire first quarter. And, January, there shouldn't be much that you would have to address. Same thing with February, because you've already addressed them. So it's just really focusing on March and making sure that what was addressed in January and February maybe fell off, and then anything new in March is addressed. And so, like I mentioned, it's a little bit more manageable than pulling quarter after quarter and waiting for that quarter to occur. You don't have to wait. Just continually do a process. And like I said, it doesn't become difficult to manage. You want to look at your facility adjusted percentage on your facility level, because that's going to tell you like your actual percentage. And then that last column, the comparison group national percentile, anything that's bolded and asterisk are your hot ticket items. You want to start addressing those first before maybe jumping into another one. So in this example, pain is not necessarily a big ticket item for this facility. So I would actually probably go with pressure ulcers and those that are bolded and asterisk first, and then maybe jump into my pain. You use that facility level CASPER report and you compare it to the resident level, because this is actually going to give you the resident's name and what quality measures they're triggering. And so another quick tip is that quality measure count, which is that last column in the report. Anything above a 3, those would be the residents that I would focus on, because that's what surveyors are probably going to focus in on. This resident that I have highlighted has 4 areas highlighted, and so the resident is experiencing falls, it's on an antipsychotic, anti-hypnotic, or hypnotic anti-anxiety, and has behavioral symptoms. You can best believe that surveyors are going to say, well, this resident is falling, probably related to their antipsychotic and anti-anxiety hypnotic medication, and they're on those medications because they have behavioral symptoms. So you can see how it's easily tied together, related to what measures they're triggering. I also recommend that you guys do a QM review, and this is just a quick mock-up of something that, these are the areas that actually trigger the quality measure. And so looking at how your MDS is coded, making sure that it's accurately coded, then looking at comorbidities that affect their pain, looking at their medications, non-pharmacological interventions, and then making sure that, if therapy isn't involved, get them involved. Making sure that appropriate consultations are occurring, maybe with the pain specialist if that's available in your area. So some tips for success is be proactive. Like I mentioned, review your CASPER reports month over month and address them immediately rather than waiting an entire quarter. Make sure that the pain interviews are conducted as close to the ARD as possible, preferably the day before or the day of the MDS. Work with the family, MDs, prior facilities on gathering a comprehensive pain history for the residents. Establish upon admission what makes pain worse or better, the types of pain they're experiencing, and establish a pain goal. I think establishing a pain goal is one of the most crucial aspects when you're evaluating your resident's pain. And then you want to ensure that the IDT is aware of the pain plan for the residents so that if pain is identified, immediate resolution can be sought. Don't forget non-pharmacological interventions. And then, like I mentioned, work with rehab for initiation of pain modalities. Be reactive, evaluating those CASPERs on a monthly basis for accuracy, and then modify MDSs if applicable. And then identify those clinical processes that need improvement. And then keep a focus on the end goal, which is quality care. A 5-star QM rating and excellent survey outcomes derived from providing quality care. So I have listed some resources at the end of this presentation if you are interested. And also my contact information, as well as New Mexico's REI state coordinator. Each state, other state that is on this call, you too also have your own state REI coordinator, and I believe they are listed in the handouts.
Yes. Okay, thank you so much, Jessica. That was really a whole lot of information in a short period of time, and I really appreciated you sharing your wisdom. While you guys are formulating your questions, couple of things. I'm just going to quickly put a link into our previous hot topics. You can access them on the Health Insight website, and they're great for using for your staff in-service training or just education afterward. Let's see, Rebecca's asking if you can get a copy of the presentation handouts. Rebecca, do me a favor, and I think you have my email address. If you just shoot me your email, I will respond back with the PDF. Okay, Leanne had a question, which was, how do you address those residents that rate their pain at levels that trigger the quality measure but are obviously not having pain at levels of 8 to 10?
So that's one of the most difficult aspects when dealing with your pain quality measure, because again, pain is subjective. So we have to go based off of how that resident is rating their pain. We as clinicians know that if a resident is truly at a 10 out of 10 pain, they would not be in activities, going outside, having their cigarette breaks, or participating in any part of their care. So no matter what, they're still going to trigger that quality measure, and it's going to affect our overall score. But it's taking a deep dive into that residence chart, making sure that our ducks are in a row related to our interventions. Have we addressed their scheduled medications? Have we addressed their PRN? Are we looking at their BIM score, which gives an idea of if they're cognitively intact? Maybe they're not cognitively intact and they forget that they have PRN pain medications that they can ask for. So it's looking at that resident, but also making sure that our documentation is very supportive of all the interventions that we've attempted. Yes, they're going to trigger, and so there's nothing we can do about it, but do we have our ducks in a row? And I think that's the biggest thing that we can do as clinicians. The other thing is, even though they're going to trigger your quality measures, try and build a cushion in your other quality measures. Your overall rating isn't based off of just pain. So if you're worried about that overall rating, try addressing, your pressure ulcers, try addressing your antipsychotics or your catheters, something like that. Build a cushion in those quality measures. So if you do have those residents that are rating their pain 10 out of 10, it's not going to throw you out of, say, that 5-star rating if you've achieved it.
Great. We have somebody who's raised their hand. Kelly, would you go ahead and try to allow Rebecca to ask her question? And while she's doing that, Arlita had a question of where do you access CASPER reports?
So you would have to go to the KEYS system, and each facility has to request access. I believe there are 2 users that can only have access per facility. Generally, it's your administrator and possibly your MDS coordinator, but sometimes it's your administrator and your director of nursing. It all just depends what works for your facility. So I would recommend contacting your administrator and see, should you have access? If so, there are steps to take to gain you access for your facility. And I believe, Arlita, you work for Genesis facilities, so if you reach out to me, I can actually help you more specifically.
Great, thank you. Okay, we've got a question from Danielle. She asks, I have many residents with dementia who have very poor short-term memory. I know they cannot remember the past 5 days because they cannot usually remember what happened even hours earlier. I always attempt an interview, but I was told once that if a resident cannot conceptualize the past 5 days, I should code the response as unable to answer. How would you code these residents based on their yes/no response?
So again, you would have to try and clarify as much as possible, what the past 5 days was. I think you're on the right track with unable to answer. So it's showing that you at least attempted the interview. And so you're going to code it unable to answer and then jump over to that staff assessment. And so again, you're at least attempting. And that's the key thing. Instead of just assuming, oh, they have dementia, I'm not even going to try and attempt this. You should at least go and try and talk with that resident, because they may surprise you. They may remember that yesterday they had very bad pain and are able to articulate that. It's kind of hit or miss, but the good thing is you are attempting it. And, based off of the answers they are giving you, you are stating they are unable to answer because it's non-coherent, I guess you can say.
Okay. So I'm going to get you back to your busy Fridays. And once again, I'd like to thank our presenter, Jessica Mirabal, for doing a fantastic job. So thank you very much. We're going to conclude half-hour Hot Topics, and enjoy your weekend. Have a wonderful rest of your day.